Good morning, doctor and friends. My name is Udayana Mahaputra with name 024. Today, we from SGD B10 will present about our student project Rehabilitation in Vertigo. Next is the list of our team members. Next, this is the contents of our presentation. Now I will begin with Chapter 1, Introduction, Background. Dizziness is one of the most frequent presenting complaints in medicine with an estimated prevalence of 17 to 30%. Vestibular vertigo, which is defined as rotational vertigo, positional vertigo, and recurrent dizziness with nausea and oscillopsia, account for 24% of vertigo or dizziness cases, with 12-month prevalence of 5%. Vertigo is often recurrent, which contributes to its high prevalence rate. Women and elderly are more susceptible to vertigo. Vertigo is not only caused by a balance problem in the inner ear, but it also can be caused by the problem in the brain.
Hello doctor and friends, my name is Vinny Valentin with the number 086. Vertigo is not only caused by a balance problem in the inner ear, but it also can be caused by a problem in the brain. Vertigo etiologies can be classified into peripheral and central disorder. The peripheral itself comprises about 70% of vertigo cases, and the most common is BPPV and Meniere's disease. The other causes, like fire-related, including acute labyrinthitis, vestibular neuritis, and herpes zoster oticus. And the next is central causes, that including stroke, especially those that affect the cerebellum or vertebrobasilar system. And there is tumor, especially tumor those arising from cerebropontine angle, such as brainstem glioma, medulloblastoma, and vestibular schwannoma.
Good morning, doctor and friends. My name is Shannon Kalista, name 015. Now, I would like to continue the presentation. Next is about the research questions. So, the research questions for the writings are: what is the definition and types of vertigo? What is the pathophysiology of vertigo? What are the diagnosis and differential diagnosis of vertigo? How is the management of vertigo? What is rehabilitation and indications of rehabilitation in vertigo? And the last one, what is the effectivity of rehabilitation in vertigo? Move on to the purposes of the writings, which are to understand what vertigo is, to enhance the knowledge about pathophysiology of vertigo, to understand the diagnosis and differential diagnosis of vertigo, to understand the management of vertigo, to understand the indications of rehabilitation in vertigo, and the last one is to understand the effectivity of rehabilitation in vertigo. Next, there are some benefits of the writings which are for public. They can acknowledge the importance of rehabilitation in vertigo. For medical community, they can further understand about pathophysiology, diagnosis, differential diagnosis, and management of vertigo. And for authors, they can enhance their knowledge about rehabilitation in vertigo. That's all from me. Next will be presented by my friend. Thank you.
Hello, my name is Putra Landere and I'm number 11. So today I will present about the definitions and classifications of vertigo. Vertigo is a term derived from the Latin vertere, which means rotating. In general, vertigo is known as the illusion or hallucinations of movement. Vertigo is found in the form of complaints of circular and vertical linear vertigo. So vertigo is a collection of symptoms or syndrome that occur due to balance disorders and the vestibular systems or central nervous system. Next, classifications of vertigo. So vertigo can be divided into vestibular and non-vestibular. And in vestibular vertigo, there are peripheral and central vertigo. Central vertigo is vertigo due to abnormalities in the central area, namely the cerebellum, and brainstem. Central vertigo is caused by stroke, neoplasm, basilar migraine trauma, or cerebral hemorrhage. Peripheral vertigo is a vertigo caused by abnormalities in the labyrinth and vestibular nerve. Peripheral vertigo can be caused by benign proximal positional vertigo or BPPV, post-trauma, Meniere's, labyrinthitis, toxic, labyrinthine occlusion, and fistule, infection, inflammation, acoustic neuroma, and other tumors.
My name is Putri Tamia Desrianti, NIM 081. Vertigo can occur because there is a disturbance in the body balance and coordination system. Sensory input comes from the vestibular, visual, and somatosensory system, which integrate in the vestibular nucleus and requires two main reflexes that are vestibulo-ocular reflex, which stabilize vision during movement, and the vestibulospinal reflex, which helps to stabilize posture. The cerebellum to perfect result of an accurate motor movement. The vestibular organs in the ear consist of the three semicircular canal, superior, lateral, posterior, and two otolithic organs, utricle and sacral. The vestibular apparatus giving the brain correct perception of the balance as well as a spatial orientation and movement. Rotational movement are detected by the semicircular canal filled with endolimb, cause cupula movement resulting in depolarization of hair cell. The endolimb move and trigger sensory receptor in the canal and sends nerve impulse to the brain regarding the movement. Vertigo will arise when there is a mismatch of information conveyed by the afferent arrangement that confuse the neuronal input. Each afferent neuron has a basic firing rate. Cutting stereocilia of the hair cell toward kinesiolium is excitatory and increase firing rate, deflection away, and cause reduction. Nerve output from one side of the semicircular canal is compared with the other side, and then the brain interprets the difference in discharge rates as movement.
Hello, my name is Manigandan Manamon Pillai and the last three digits of my name is 249. Today I'll be talking about the diagnosis and the differential diagnosis of vertigo. To ensure the diagnosis of vertigo, an otolaryngologist performs a physical examination to look for sign and symptom of the cause of vertigo in a patient. The doctor also uses an instrument to magnify and examine the ear canal and the eardrum. The doctor may also examine the eye movement and ask to track an object from one point to another. And if the patient experiences rapid eye movement or blurred vision, the doctor will refer them to an eye doctor. For the differential diagnosis of vertigo, there are many, such as dehydration, hypoglycemia, atherosclerosis, menopause, Parkinson's disease, diabetic neuropathy, and many more. That's all from me today. Thank you.
Hello, my name is Keshendrawan, number 40. So let's talk about the management. The management of vertigo is divided into three: pharmacological, non-pharmacological, and surgical. To reduce vertigo symptoms, doctors usually give vestibular suppressant drugs such as antihistamine, for the example betahistine and clonazepam, then benzodiazepine such as diazepam and lorazepam, and antiemetics to relieve symptoms of nausea. In patients with BPPV, non-pharmacological treatment can be done by giving therapy with particle repositioning maneuver, and the purpose of the maneuver is to return the particle to its initial positions at utricle macula. There are 5 maneuvers that can be performed, including Epley maneuver, Simon maneuver, Lampert maneuver, Ford's prolonged position, and Brandarov exercise. And the last management is surgical. There are 2 intervention options with surgical techniques such as singular aneurectomy or posterior ampulla nerve transection and posterior semicircular canal occlusion. Thank you.
Hello everyone, my name is Putu Emilia Dewi with student number 028. So I will explain about the indication of vertigo rehabilitation. Below are some vertigo rehabilitation indication. The first one is benign paroxysmal positional vertigo or BPPV. So the most patients with BPPV report a lower grade of dizziness after having vertigo rehabilitation. The second one is no progression of vestibular injury. The patient with stable vestibular lesion are recommended to have vertigo rehabilitation. These kinds of conditions have better prognosis to regain maximum function and quality of life. The third one is mild traumatic head injury. And then there is stable central deficit, stable mixed central and peripheral lesion, behavioral disorders, older adults, and uncertain cause of vestibular injury. Meanwhile, below are some conditions when vertigo rehabilitation is useless. The first one is in an unstable vestibular injury, an unstable central deficit, progressive mixed central and peripheral lesions, spontaneous balance problem, Meniere's disease, and perilymphatic fistula.
My name is Pierre. My last 3 digits of student number is 077. So there are 2 methods of rehabilitation we use to treat patients with vertigo. The first one is VRT, or vestibular rehabilitation therapy. In this therapy, the patients will improve by improving the vestibular adaptation, which is one of the brain mechanisms to compensate with vertigo symptoms. VRT is done by a specialized professional in physiotherapy and usually takes up to until 9 weeks to recovery. Here's the picture of the VRT. And the next one is CRP, or canal repositioning procedure. In this rehabilitation, the patient usually is suffering from PPPV, and this procedure helps the patient by moving cannulate or the crystal to the absorbed part of the vestibular system. Once the displaced cannulate is fully absorbed, the patients will eventually feel better.
Hi everyone, my name is Daniel Sungutama Maringo with the last student number 045, and I'm going to explain about the effectivity of vertigo rehabilitations. Vestibular rehabilitation therapy or VRT is effective in treating vertigo. VRT combined with common medicine treatment can better eliminate the symptom of vertigo, improve patient's quality of life, and make the patient more satisfied with treatment. A study found that the group of patients with vestibular rehabilitation training combined with drug treatment have a better outcome than the drug-only group in all vertigo scores, and the treatment success was more accurate. Another study also stated that early referral for vestibular rehabilitation in patients with vertigo results in enhanced quality of life. Further methods of therapy will be explained by my friend. Thank you.
Hello, my name is Jonathan Edmond with student number 137. Right now I want to continue with the activity of rehabilitation for cannulate repositioning procedure. A study done by Kumar in 2016 comparing the effectiveness of cannulate repositioning procedure and brain therapy exercise in treating benign paroxysmal positioning vertigo or BPV. In their study, they divided 30 patients into two groups. Group A was 15 patients treated with cannulate repositioning procedure, and Group B was 15 patients treated with brain therapy exercise. Total percentage improvement in Group A was 70% and Group B 50%. The improvement might be related to the displaced octosonia into the semicircular canal stimulates vestibular nerve, which causing nystagmus and vertigo. By performing cannulate repositioning procedure, these octosonia were positioned to cupula, resulting in decrease of abnormal stimulus on vestibular nerve, which later caused nystagmus and vertigo subsides. In Group B, the brain therapy exercise recurrence were more often than patients in Group A. This may be due to brain therapy exercise mainly depend on accommodation of the central nerve system to provoke stimulus. Group B also had less efficiency for temporary reduction compared to Group A. From this study, it could be concluded that the cannulate repositioning procedure is more effective than brain therapy exercise. It is also less time consuming in treating the benign paroxysmal positional vertigo and brain therapy exercise. And the subject treated with cannulate repositioning procedure also found to have less recurrence than the subject treated with brain therapy exercise. However, although many studies have shown that brain therapy exercise is less effective than other therapies in treating BPV, it can still be administered as primary treatment option for patients that cannot be treated with cannulate repositioning maneuver. For example, patients with cervical problems or carotid stenosis. Thank you.
Om Swastiastu. My name is Chakra Sintan Scotty with 3 digits of student number 231, and I'm going to conclude our entire presentations. So vertigo is an association of symptoms consisting of both autonomic and somatic symptoms and also dizziness that can occur due to balance disorder in the vestibular system or in the central nervous system. It is also known as the hallucination of movement, and vertigo can be divided into two classifications, which is peripheral vertigo and central vertigo. It will arise when there is a mismatch of information that can confuse the neural input. To ensure the diagnosis of vertigo, it required a history taking and a physical examination to look the sign or symptoms of the vertigo. For the differential diagnosis, it could be benign paroxysmal position vertigo, brain tumor, migraine, hypotension, and etc. And for the management of vertigo, it divided into three. It's pharmacological treatment, non-pharmacological treatment, and it's surgical treatment. For indication of rehabilitation, it can be if the patient has a BPV, stable vestibular injury, risk factors such as elderly adults, and etc. And for rehabilitation, it is no longer effective if the patient had unstable vestibular injury, unstable central deficits, and etc. And for rehabilitation itself, it can be vestibular rehabilitation therapy or VRT, which could be eliminate symptoms and improve patients' quality of life, and it could be very effective if combined with the pharmacological treatment. And the second one is the cannulate repositioning procedure, which could decrease of abnormal stimulus on the vestibular nerve. Next. So this is our references. Next. Thank you for your attention. I hope it is beneficial. Om Santi 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 Om.